Today we are going to go through some checks for the LifePak 12 monitor and defib. First we turn to the back and check the charge of the batteries. We can do this by clicking the grey button next to the battery symbol. This battery needs to be recharged, so we can push the button to the side of the battery, take it out to replace it with either a fresh battery or charge this one. And they just click back in. Next we'll come back to the front, turn the monitor on. Initially it will enter AED mode and we are going to want to take it to manual mode. We do this by clicking advisory. Using the selector toggle, selecting yes. There we go. Next we'll take it through a user test, and we do this by clicking options, scrolling over to user test and selecting it. Now that the user test is in progress, I'll take you through some of the other equipment found in the kit. Over here on the left hand pocket we have the SpO2 gauge, the non-invasive blood pressure cuff, the ETCO2 reader, and also a 4-lead ECG cables with sticky tabs attached. Each of these cables has 2 letters indicating where they need to be attached to the patient. For example, LL, left leg, or RA, right arm. The arm electrodes are attached up here, and the leg electrodes can be attached either on the legs or at the lower of the rib cage. When checking this compartment, we need to go through all of the cables, ensuring that there is no damage or no pieces missing. Next we'll go to the back, checking the rear pocket for ECG paper, spare electrode tabs, and also some spare defib pads. Over to the right hand pocket we should have a test load, defib pads in date, leads for attaching the defib pads and the test load, and also a small plastic bag containing a razor, some aspirin and some GTN. For these medications we need to check the expiry dates. Both of these are good to go. Now when we come back to the front, the user test is completed and it has printed out a summary of the test. When choosing to print manually for the readings on the screen, we can click print, and the same, clicking print again to stop it. When we would like to change between leads that we're using, we can click the button lead and scroll through those and choose whichever one we're about to use. In the same sense, we can change the size of the ECG reading by clicking the size button and scrolling through those and selecting one with the selector button. Next, for using the non-invasive blood pressure cuff, we will click the NIBP button, and for changing the QRS volume, we will scroll to the heart rate section, select it, select QRS volume, and use the toggle to scroll and change the volume. Now to exit back out, we'll need to click the home screen. We'll now go through testing the defib section of the monitor. I'll attach the test load. Now I'll click energy select. When using a test load, we need to charge to 50 joules. Using the selector toggle to select that. We now click charge. Once it's fully charged, we can click shock. Shock administered. And when we have charged a shock and we choose not to use it, we can click energy select, 50 joules for the test shock, charge, and at any time during the charging or once the charge has completed, instead of clicking shock, we can click the selector button to disarm the shock or dump shock. Finally, for checking the ECG paper, we can pull the tab underneath, open the flap and pull out the empty roll or replace it with a new one. When replacing a roll, we need to keep the grid up, insert it in with the paper feeding forwards from the top, and that should click closed. Finally, to get out of manual mode back into AED mode, we click Analyze.
Analyzing now. Stand clear.
And that is the checks for the LifePak 12. I can identify this as oxygen because it is in a white cylinder. It should be labelled medical oxygen, and it also has 3 ports on the pillar valve. First, we'll check the regulator for any damage, paying particular attention to the Bodox seal, which I can remove. Doesn't seem to have any damage or wear and tear. I'll put that back in. We can attach the regulator, first inserting the 2 prongs and then tightening the T-bar to finger tight. We'll turn on the pillar valve on the oxygen bottle, keeping an eye on the gauge to see how full the bottle is. We'll now turn it off bleeding the regulator and paying attention to the flow rates at the same time. The regulator could now be removed. For the purposes of this video, I've held the oxygen bottle standing up, but it should be stored lying down or fastened securely in the ambulance. When testing the suction unit, first we will check all of the piping and the connections to ensure that there is no visible damage, including the rigid catheter. Next, we will occlude the pipe, holding down the test button and turning the unit on full power. As it rises in vacuum pressure and checks the battery, it will turn off once it has passed the test. It has passed. When using a suction unit on a patient, they need to be lateral in the side stable or recovery position. We will gently insert the rigid catheter no further than we can see, occluding the hole with our finger on the rigid catheter, completing the suction circuit, using in circular motion in outward direction. We will suction for no longer than 10 seconds. Some complications include soft tissue damage, laryngospasm, and induced vomiting. Today we're going over some checks in the first response kit. When we're going through, we want to make sure we have sufficient quantities of everything and that everything is clean and undamaged. In our top outer pocket, we have a small and large blood pressure cuff, a stethoscope, clothing shears, tympanic thermometer with covers, a pupil torch, and blood glucose meter with test strips. Next pocket down is miscellaneous items. In this case, we have some PPE in the form of safety glasses. In our large side pocket, we have our trauma gear, including some triangle bandages, a couple of crate bandages, 2 different sizes of tapes and saline ampules, some tourniquets, steri strips, gauze squares, and combine dressings. In our upper outer pocket, we have an emesis bag, a cervical spinal lanyard, ethyl chloride, and N95 masks. In our lower side pocket, we have some IV glucose, oral glucose, glucagon, a 60ml syringe with a drawing up needle, and a fluid administration kit. Moving to the inside, in our upper pocket, we have some medications, including mefloxiflurane, some paracetamol, ibuprofen, tramadol, ondansetron, and loratadine. We would like to check the expiration dates on all of these, including the mefloxiflurane. Next pocket down, we have a yellow biohazard bag, some laryngoscopes, and a number of ranges of OPAs, MPAs, some McGill forceps, and some lube sachets. On the lower inner pocket, we have some oxygen tubing, nasal prongs, a adult and child nebulizer mask, and a nebulizer. Over to the side of that, we have some adrenaline, salbutamol, and ipratropium, and we are going to check the expiration dates on those, and that all ampules are intact. In the base of our kit, we have a number of miscellaneous items, including a towel, some cardboard splints, C-spine collar, slippery Sams, a sharps container, and some sodium chloride. We also have an IV roll, an LMA kit, and 2 manual ventilation kits for children and adults. For both of these manual ventilation kits, we should have a bag valve mask, including a reservoir bag and a resus mask. We also have a reservoir mask, a filter, PEEP valve, and some oxygen tubing. We're just going to do a couple of checks on these, ensuring that there is no damage to the mask, that the bag is holding firm, and that there are no leaks. And we'll also do some checks on the reservoir bag, ensuring that there are no leaks. And there aren't. And those are our checks on our first response kit. We have been dispatched to a 58-year-old male who has collapsed at a university in Manukau. Hospital is 15 minutes away and backup is approximately 7 minutes away. When approaching a scene, we can assess our dangers using the SETUP acronym. First, sizing up the scene. Do we have enough room for working, and keeping an eye out for potential mechanism of injury. Next, we can look at our environment and the traffic. Today our access and egress was a little difficult. We had to navigate through the university to locate the scene. We also had to access stairs. Next we can look at our unpredictables, things such as bystanders or pets. Finally we have our personal protective equipment, our gloves, glasses, boots, and we also have all of our gear. When initially reaching the patient, initial assessment is they're lying on their back, unresponsive, no signs of respiratory effort or obvious signs of trauma. Hello sir, my name's Shanti. I'm here with Carly, we're here from the ambulance. Could you please set up my gear? Patient has no response to voice or pain. I'm now going to use a head tilt chin lift to look in his airway, which is unobstructed. Now I'm going to listen and feel for breathing for 10 seconds. Feeling for chest rise and fall. Listening for breathing. Patient is not breathing and is in cardiac arrest. Carly, could you please begin compressions? I'm now going to set up the defibrillator. Working around Carly. Placing the pads on the patient. Now I'm going to call for backup off the chest. ABT1 to comms requesting an R50 to 640 Great South Road.
Shock advised.
Back on the chest.
Charging.
I'm now going to begin to manage the patient's
Stay
airway.
clear of patient.
I'll first do this by placing a towel under the patient's head.
Deliver shock now. Press the orange button
Off the chest.
now.
Shocking. Everybody clear.
Shock delivered.
Shock delivered back on the chest.
Pause.
I've placed a towel under the patient's head to keep their head in a tilted back sniffing position. I'm now going to set up an OPA and an NPA to maintain the patient's airway because they can't maintain it themselves as they have a GCS below 8. OPA is measured from the corner of the mouth to the corner of the mandible. Is inserted upside down, inserted gently into the patient's mouth, twisted 180, catching the tongue. Some complications of using an OPA include soft tissue damage, laryngospasm, and trismus or emesis, and induced vomiting. And OPA is not used if the gag reflex is intact. And NPA is measured from the corner of the nostril to the corner of the mandible and is inserted through the largest nostril. We can twist it to insert it, and this needs to be lubed up before we have used it. If resistance is felt, we can take it out and insert it into the opposite nostril. Some complications of using an NPA include nasal polyps and bleeding, and we would not use an NPA if the patient had major head trauma. I'm now going to set up oxygen and ventilations. This is used with a bag valve mask, connecting it up to oxygen and a flow rate of 10 to 15 litres per minute. Carly, could you please count the compressions out loud from 25? In the chance that induced vomiting occurs, I have got suction on hand. When using a bag valve mask, we need to keep a firm seal on the patient's face, using a CE grip. Keeping an eye on chest rise and fall, back on the chest. Administering 2 ventilations to 30 compressions, squeezing the bag a third of the way. We need to keep an eye on chest rise and fall.
Stop CPR.
We will swap places now to maximise the amount of time for compressions on the chest, preventing fatigue with CPR performers.
Analyzing heart rhythm. No shock advised. Pause.
Carly, can you please make sure that the patient's head is tilted back using a CE grip? Some complications of using a bag valve mask include gastric inflation and increased intrathoracic pressure, which decreases venous return. Troubleshooting gastric inflation, we can apply cricoid pressure. Carly, could you please demonstrate? In this case, the CPR performer will need to squeeze the bag valve. Keeping an eye on adequate chest rise and fall. If a firm seal on the patient's face cannot be found, we can use a double-handed grip on the mask on the patient's face. Carly, could you please demonstrate? 26, 27, 28, 29, 30. And in the same case, the CPR performer will need to squeeze the bag valve. At this time, CPR performers can be asking bystanders if there are any about what happened at the event of the accident or injury. In this case, did you witness the collapse? Do you have any medical history of the patient? Do you know any medications they may have been taking, or any idea of why they may have collapsed? CPR can be stopped in the event of fatigue. CPR performers will continue switching places in cycles of 26, 27, 28, 29, 30. Doing ventilations to compressions. We can also stop CPR in the event that backup turns up, in the event of return of spontaneous circulation, or when the patient is declared clinically dead. If CPR performers experience fatigue, we can coach bystanders into how to perform CPR. We use locked arms and compress at a depth of a third of the chest cavity using 100 to 120 compressions per minute.